If you are over 60 and your memory has started to feel different, do not blame age just yet, because sometimes the problem is not your brain aging, and sometimes it is not the beginning of dementia. Sometimes it is something sitting quietly in your medicine cabinet, a sleep aid from the drugstore, an allergy pill you have taken for years, a bladder medication you were told was routine, a nerve pain pill that helped your feet but slowed your thinking, or a combination of medications that no one has ever looked at all together. I'm William, and I help older adults understand the health questions worth bringing to their doctor. And today we are going to talk about 9 common medications and medication categories that may quietly affect memory, attention, alertness, or thinking after 60. Before we begin, I need to be very clear about something important. This video is for education only. It is not personal medical advice. Do not stop, start, skip, lower, or change any medication because of a YouTube video. Some of the medicines we discuss today can be necessary, even life-protecting, for the right person. The goal is not fear. The goal is awareness. The goal is to help you ask better at your next primary care visit, pharmacy consultation, Medicare wellness visit, or medication review. Because one of the most common mistakes I see families make is assuming every change in memory is aging. A parent repeats the same question 3 times, and everyone whispers, dementia. A husband starts losing the thread of conversations, and the family says he is just getting older. A woman who used to manage bills, prescriptions, grocery lists, and appointments suddenly feels foggy, and nobody asks what changed in the pill organizer. But medications can affect the brain in ways that are easy to miss. They can cause drowsiness, slower reaction time, poor coordination, confusion, reduced attention, memory gaps, or a foggy feeling that looks a lot like early cognitive decline. And in older adults, this matters more because the liver, kidneys, brain, balance system, sleep cycle, and nervous system do not handle medications the same way at 75 as they did at 45. A dose that was tolerated years ago may become too strong. A medicine that was safe by itself may become risky when stacked with 3 others. An over-the-counter pill that seems harmless may affect the same brain chemical your memory depends on. So today, we are counting down 9 medications worth discussing with your doctor or pharmacist if memory, alertness, balance, or thinking has changed after 60. Stay with me until the end, because the last lesson is the one most families miss. Often the biggest danger is not one pill, a combined burden of several ordinary pills taken together. Number 9 is older allergy and nighttime sleep medicines, especially diphenhydramine, doxylamine, and some older antihistamines. You may know diphenhydramine by names like Benadryl, and you may see it hiding inside products labeled PM, nighttime, sleep aid, allergy relief, or cold and flu. You may know doxylamine from some over-the-counter sleep products. These medicines are sold at CVS, Walgreens, Walmart, grocery stores, and sometimes even gas stations, so many people assume they are gentle. But over-the-counter does not automatically mean brain-safe for older adults. The key issue is that many older antihistamines can have anticholinergic effects. That means they can block acetylcholine, a chemical your brain uses for attention, alertness, learning, and forming new memories. Imagine acetylcholine as the ink your brain uses to write down the day. If that ink is low, the brain may still move through the day, but it may not record the day clearly. That is why a person may take an allergy pill or PM pain reliever at night and wake up feeling heavy, slow, forgetful, dry-mouthed, constipated, dizzy, or strangely disconnected. The person may say, "I just do not feel sharp anymore." The family may say, "Dad is starting to slip." The first question may be, "What is he taking at night?" This is especially important because these ingredients often appear in combination products. A bottle may say pain relief, PM. The PM part may be diphenhydramine. A cold medicine may contain several ingredients, including a sedating antihistamine. Someone may not realize they are taking the same brain-slowing ingredient from two different bottles. Here is the practical move. Tonight, look at every bottle in the house that says PM, nighttime, sleep, allergy, cold, flu, or sinus. Turn it around and read the active ingredients. If you see diphenhydramine or doxylamine, do not panic and do not abruptly stop something you have been told to take for a serious reason, but ask your pharmacist, is this appropriate for me at my age, with my memory concerns, my fall risk, my prostate or bladder issues, my glaucoma risk, and my other medications? That one question can prevent a lot of confusion. Number 8 is prescription sleep medicines, especially zolpidem, along with related medicines such as esopiclone and zaleplon. Many people know zolpidem by the brand name Ambien. These medications are sometimes called ZED drugs. They are prescribed for insomnia, and for someone who has gone weeks without proper sleep, they can feel like a miracle at first. But they work by slowing activity in the brain, and in older adults, that slowing can sometimes spill into the next day. A person may sleep but wake with poor coordination, slower reaction time, memory gaps, daytime sleepiness, or reduced alertness. Some people have reported complex sleep behaviors, meaning they may get out of bed, eat, make phone calls, walk around, or even do something dangerous while not fully awake and then have little or no memory of it later. That is not ordinary forgetfulness. That is a drug effect worth taking seriously. The risk becomes even greater if a person wakes up at 2 a.m. to use the bathroom because now you have darkness, possibly low blood pressure from standing up, sleepy balance, and a medication still active in the brain. That is how a sleep problem can turn into a fall problem, and a fall problem can turn into a loss of independence. I am not saying nobody should ever use these medicines. I am saying they deserve review, especially if they have become a nightly habit for months or years. Ask your doctor, is this still the safest sleep option for me? Am I on the lowest useful dose? Could this be affecting my memory, balance, or morning alertness? Could cognitive behavioral therapy for insomnia, better sleep timing, morning light exposure, reducing late caffeine, treating pain, treating sleep apnea, or changing another medicine help me sleep without relying on this every night? Sleep matters deeply, but drugged sleep is not always the same as restorative sleep. Number 7 is benzodiazepines, including alprazolam, lorazepam, diazepam, clonazepam, and temazepam. Many people know the brand names Xanax, Ativan, Valium, Klonopin, and Restoril. These medicines are often prescribed for anxiety, panic, muscle tension, alcohol withdrawal, or sleep. And I want to speak with compassion here because anxiety is real, panic is real. Sleeplessness is real. When someone is suffering, a medication that finally calms the body can feel like rescue. Benzodiazepines work by enhancing GABA, one of the brain's calming signals. That can quiet an overactive nervous system. But after 60, and especially after 70, the same calming effect can also mean slower thinking, weaker memory formation, worse coordination, reduced reaction time, and increased fall risk. Think of the brain like a house with lights in every room. Anxiety may feel like every light is too bright and every alarm is ringing. A benzodiazepine turns the lights down. Sometimes that is useful. But if the lights are turned down too far, you cannot read the labels, you cannot see the stairs, and you cannot find your way through a conversation as easily. That is why some people on long-term benzodiazepines describe feeling emotionally flattened, mentally slowed, or less like themselves. The most important safety warning is this: do not suddenly stop a benzodiazepine. Stopping too fast can be dangerous and can cause severe withdrawal, rebound anxiety, insomnia, agitation, tremors, and in some cases seizures. This is not a medication to quit in a burst of motivation. It requires a doctor-guided plan if a change is needed. The questions to bring are: do I still need this medication? Is the dose still right for my age? Could this be affecting my memory or balance? If I need to come down, what is the safest taper plan? Are there safer long-term options for anxiety or sleep, such as therapy, an SSRI that is appropriate for older adults, buspirone, breathing training, or treating the underlying cause of insomnia? The goal is not to take away relief. The goal is to protect relief and clarity at the same time. Number 6 is bladder control medication, especially oxybutynin and sometimes related medications used for overactive bladder. This is a delicate topic, but it matters. Overactive bladder can steal a person's life. People stop taking road trips. They avoid church, restaurants, long walks, family gatherings, and shopping trips. They plan their entire day around the nearest bathroom. So yes, treating bladder urgency matters. But some bladder medicines work by blocking signals that cause bladder contractions, and some do this by blocking acetylcholine. Remember acetylcholine from earlier? That is the same brain chemical involved in attention and memory. So, a medication may calm the bladder while also making the brain less sharp in some older adults. Oxybutynin is one of the names families should recognize. It can cause dry mouth, constipation, blurry vision, dizziness, sleepiness, and confusion. Those symptoms may sound minor on a package insert, but in real life, they can change. Dry mouth leads to less drinking. Less drinking leads to dehydration. Dehydration worsens confusion and dizziness. Constipation worsens discomfort and sleep. Dizziness increases fall risk. And confusion gets blamed on age. The person may say, "I just feel off." The daughter may notice repeated questions. The spouse may notice that the person who used to follow complex conversations now loses the thread. But because bladder symptoms are private, many families never connect the dots. If you take a bladder medication, ask your doctor or pharmacist, is this anticholinergic? Is it known to affect memory or thinking in older adults? Is there a bladder treatment with less effect on the brain? Could pelvic floor therapy, bladder training, fluid timing, reducing evening caffeine, treating constipation, or another medicine be safer for me? Do not stop a bladder medication on your own because symptoms can return and affect quality of life. But do not ignore new brain fog either. You should not have to choose between dignity and mental clarity without a careful conversation. Number 5 is older tricyclic antidepressants, especially amitriptyline and sometimes nortriptyline, imipramine, or higher dose doxylamine. These medicines are interesting because many people are not taking them for depression at all. They may be taking a small dose at night for nerve pain, migraine prevention, sleep, chronic pain, fibromyalgia type symptoms, or post-shingles pain. And because the dose may be low, people assume it cannot matter. But dose is only part of the story. Amitriptyline can have strong anticholinergic effects. It can dry the mouth, slow the bowels, blur vision, cause sleepiness, and affect thinking in some older adults. A person may take it at bedtime and then spend the next morning pushing through a fog. After months, that fog becomes normal. the person stops questioning it. They say, I guess this is just what my 70s feel like. But what if it is not age? What if it is a medication hangover happening every single day? This is why the question, why am I taking this, is so powerful. Many people have taken the same medication for years without knowing whether the original reason still applies. If you are taking amitriptyline or a similar medication, ask, what condition is this treating right now? Is it still working? Is it contributing to dry mouth, constipation, dizziness, sleepiness, or brain fog? Is there a safer option for nerve pain, migraine prevention, sleep, or mood at my age? Could the dose be lowered, switched, or timed differently? And again, do not suddenly stop. Some medications need gradual changes to avoid withdrawal symptoms, rebound pain, or mood effects. Number 4 is paroxetine, known by the brand name Paxil. This one surprises people because paroxetine belongs to the SSRI family, and many people think of SSRIs as newer and cleaner than older antidepressants. Many SSRIs can be very helpful and appropriate. Depression and anxiety themselves can harm memory, sleep, motivation, and quality of life, so treating them matters. But paroxetine is different from some other SSRIs because it has more anticholinergic activity. That means it can be more likely than certain alternatives to cause dry mouth, constipation, sleepiness, and possible cognitive side effects in some older adults. It is used for depression, panic disorder, social anxiety, generalized anxiety, PTSD, and sometimes hot flashes. For some people, it has been genuinely helpful, but in older adults, especially someone noticing memory changes, paroxetine deserves a review. One of the tricky parts is that paroxetine can also be hard to stop abruptly. If stopped suddenly, it can cause withdrawal symptoms such as dizziness, irritability, mood changes, anxiety, sleep disruption, confusion, headaches, and other uncomfortable effects. That means a person should never simply decide, I saw a video and I am done. Instead, the better move is to ask, is paroxetine still the best choice for me at my age? Are there other antidepressants or anxiety treatments that may have fewer anticholinergic effects? If we decide to change, what is the safest taper plan? Could my symptoms be from the medication, from depression itself, from sleep problems, from thyroid problems, from B12 deficiency, or from something else? This is the careful approach. You do not abandon mental health treatment, you refine it. Number 3 is gabapentin and pregabalin, often used for nerve pain, shingles pain, restless legs, seizures, and sometimes other off-label reasons. Gabapentin can be very useful for certain people. If you have burning nerve pain after shingles or neuropathy keeps you awake, relief matters. But gabapentin acts on the nervous system, and in older adults, it can sometimes cause drowsiness, dizziness, unsteadiness, slower thinking, or a foggy feeling. This is especially important for people with reduced kidney function because gabapentin is cleared through the kidney. If kidney function declines, the same dose can become stronger than intended. And kidney function often declines quietly. A person may not feel it. They may only notice that a medication they tolerated before now makes them sleepy, confused, or wobbly. Families often describe this as decline. They say, she is weaker this year. He is sleeping all day. Mom is not as sharp. The question that should be asked is, has anyone checked whether the dose still matches kidney function? This category also becomes riskier when combined with other brain-slowing medicines such as opioids, benzodiazepines, sleep medicines, alcohol, or muscle relaxants. One sedating medicine may be tolerable, 2 may be too much, 3 can become dangerous. If you take gabapentin or pregabalin, ask your doctor or pharmacist. Is my dose adjusted for my kidney function? Could this be causing sleepiness, dizziness, balance problems, or brain fog? Do I still need the same dose? Could we treat the pain with physical therapy, topical options, better diabetes control, sleep improvement, or another approach that lets me use less medication? Pain relief is important, but staying alert and steady is also part of pain care. Number 2 is opioid pain medicine, including hydrocodone, oxycodone, morphine, codeine, tramadol, and related medications. Opioids can be necessary. After surgery, severe injury, cancer pain, or certain serious conditions, they can be appropriate and humane. Nobody should be shamed for needing pain relief, but opioids act directly on the brain and nervous system, and they can cause sedation, dizziness, confusion, constipation, slowed breathing, and increased fall risk. The risk becomes much higher when opioids are combined with benzodiazepines, sleep medications, alcohol, muscle relaxants, gabapentin, pregabalin, or other sedating drugs. Think of your alertness like a dimmer switch. One medicine lowers it a little, another lowers it more. A third lowers it enough that the person is technically awake but not fully present. That is when people forget conversations, stumble at night, breathe too slowly, miss doses, double doses, become constipated enough to get sick, or seem suddenly unlike themselves. Tramadol deserves special caution because many people think of it as a lighter pain pill, but it can still cause dizziness, sleepiness, confusion, and interactions, and it may affect seizure risk or serotonin-related interactions in some people. Another common scenario happens after a hospital stay. An older adult comes home with a new pain medicine. They already had a sleep aid. They already had an anxiety medication. They already had gabapentin. Now the stack is heavier and no one has simplified it after the acute problem improved. If you or someone you love uses opioid pain medication, ask, how long should I need this? What is the plan to reduce or stop it when pain improves? Is it safe with my sleep medicine, anxiety medicine, nerve pain medicine, or alcohol use? What side effects should my family watch for? What should we do if I become unusually sleepy, confused, or short of breath? Severe sleepiness, slowed breathing, blue lips, inability to wake, or severe confusion can be an emergency. Call for urgent help. Pain should be treated, but not at the cost of preventable harm. Number 1 is antipsychotic medication used in older adults, especially when used for sleep, agitation, or behavior symptoms without a careful ongoing review. Names include quetiapine, risperidone, olanzapine, and others. These medications have important uses in conditions such as schizophrenia, bipolar disorder, severe agitation, and certain psychiatric situations. They can be necessary, but they are powerful brain-active medications, and in older adults, they require respect. Quetiapine, for example, is sometimes used off-label as a sleep medicine because it can be sedating. That does not mean it is a simple sleep aid. Antipsychotics affect brain chemicals involved in mood, perception, motivation, movement, and alertness. In some older adults, it can contribute to sleepiness, slowed thinking, dizziness, movement problems, falls, metabolic changes, or a sense that the person is emotionally dulled. There is also a major safety warning for older adults with dementia-related behavior problems. Antipsychotics are not approved by the FDA for behavior problems in older adults with dementia, and they may increase serious risks in that population. This is not a small detail. Families need to know why the medication was started, what symptom it is treating, whether it is still needed, what the target outcome is, and when it will be reviewed. In nursing homes, assisted living, hospitals, and busy caregiving situations, sedating medications can sometimes be continued because they make behavior easier to manage. But easier is not always safer. If someone you love is taking quetiapine, risperidone, olanzapine, or another antipsychotic, ask directly, what is the diagnosis or symptom this is treating? Is it being used for sleep, agitation, psychosis, bipolar disorder, or something else? What benefit should we be seeing? What side effects should we watch for? Is the dose the lowest effective dose? How often will we try to reduce or reassess it if appropriate? Are pain, constipation, infection, dehydration, loneliness, hearing loss, poor sleep, or overstimulation to the behavior? That last question matters because agitation is often communication. A person may not be difficult. They may be in pain. They may need to urinate. They may be constipated. They may be scared because they cannot hear. They may be overstimulated by noise. They may be reacting to a medication. The answer is not always another pill. Now, before we finish, I want to pull all 9 together because the pattern matters more than memorizing every name. The medications we discussed can affect the brain through a few main pathways. Some block acetylcholine, the memory and action chemical. That includes older antihistamines, some bladder medicines, some older antidepressants, and paroxetine to a lesser degree than many classic anticholinergics. Some slow brain activity directly, including benzodiazepines, Z-drugs, opioids, antipsychotics, and sometimes gabapentin or pregabalin. Some increase fall risk through dizziness, poor coordination, low alertness, or blurred vision. Some become more powerful when kidney or liver function changes, and some become risky only when stacked with other medications. That is the hidden lesson. Your brain does not experience each pill separately. Your brain experiences the total load. One person may take diphenhydramine for sleep, oxybutynin for bladder urgency, amitriptyline for nerve pain, gabapentin for neuropathy, and hydrocodone after a dental procedure. Each one has a reason. Each one may have been started by a different clinician, but together they may create a brain fog that looks like aging. This is why a medication review can be one of the most powerful health moves after 60. It is not dramatic. It does not require a miracle. It requires a table, a bag, every bottle in the house, and a professional who has time to look at the full picture. Here is your action plan for this week. Step 1. Gather everything. Prescription bottles, over-the-counter sleep aids, allergy medicines, cold medicines, pain relievers, supplements, herbal products, creams, patches, eye drops, bladder medicines, and anything labeled PM. Step 2. Write down the name, dose, how often you take it, why you take it, who prescribed it, and when it was started. Step 3. Circle anything that makes you sleepy, dizzy, constipated, confused, dry-mouthed, unsteady, or less alert. Step 4. Bring the list to your pharmacist or primary care doctor and ask 5 questions. Which of these can affect memory or alertness? Which of these are anticholinergic? Which of these increase fall risk? Which of these are still necessary? Can any dose be lowered, switched, simplified, or stopped safely under medical supervision? Step 5. If memory changes came on suddenly, do not wait months. Sudden confusion can come from infection, dehydration, low sodium, low blood sugar, medication interactions, stroke, head injury, oxygen problems, or other urgent causes. If someone has sudden severe confusion, weakness on one side, trouble speaking, chest pain, trouble breathing, fainting, hallucinations, falls, or cannot be awakened normally, seek urgent medical care. Do not assume dementia. Do not assume age. Ask best. And one more thing, when you talk to your doctor, do not walk in saying, "I want off all my medications." That puts everyone in a defensive position. Instead, say, "I am concerned about memory, alertness, and fall risk. Can we review whether any of my medications could be contributing?" That is a better conversation. It is calmer, safer, and more likely to help. If this video made you think of someone, send it to them. especially if they are over 60, taking several prescriptions, using PM sleep products, or suddenly feeling foggy. And in the comments, tell me your age and how many medications you take every day, including over-the-counter pills. You can write something simple like 71, 5 prescriptions and 2 OTC, or 64, 1 prescription but nightly sleep aids. I read the comments because they help me know what to cover next. If you want more clear, practical, senior health videos like this, subscribe and turn on notifications. Every week, we talk about the questions older adults and families should be asking before small problems become life-changing ones. Remember, this video is educational only. Never stop, start, or change a medication without speaking with your doctor or pharmacist. But do not ignore your medicine cabinet either. Memory is precious. Independence is precious. And sometimes protecting both starts with asking one simple question. Could this pill, or this combination of pills, be part of the problem? Next, I'll show you 8 causes of brain fog after 60 that are not dementia, and several of them are much more common than most families realize. Stay alert, ask better questions, protect your independence,